Let's go ahead and call the interim meeting of Vehicle Health and Insurance and Long-Term Care Issues Committee to order. Will, if you're on there, will you please take a roll call?
Sure. Thanks, Mr. Chairman. So we'll start with committee members that have registered for this meeting. California Assemblyman Tim Grayson.
Here.
Connecticut Representative Tammy Nuccio. Idaho Representative Rod Furness.
Here.
Indiana Representative Matt Lehman.
Here.
Kentucky Representative Deanna Gordon.
Yes.
Louisiana Senator Robert Mills. North Carolina Senator Vicky Sawyer. New York Assemblyman Jared Gandolfo. New York Assemblywoman Pam Hunter.
Here.
New York Senator Pam Helming. Ohio Senator George Lang.
Here.
South Carolina Representative Carl Anderson. Texas Representative Tom Oliverson. Okay, so we'll move on to non-committee members that have registered. Colorado Representative Daphne Michelson Janae.
Present.
Kansas Representative Bill Riley. Illinois Representative Rita Mayfield. Massachusetts Representative David LaBouffe. Michigan Representative Christian Grant. North Dakota Senator Jeff Barta.
Present.
New York Assemblyman David Weprin. Oklahoma Representative Mark Tedford. Washington Representative Mai Lin Tai.
Here.
Wisconsin Representative Lisa Subeck. And we do have Chair Westfall here. And Mr. Chairman, we will just need a motion to waive the quorum requirement.
Yes, I need a motion to waive the quorum requirement. Do I hear a motion?
So moved. Pam
Do I hear a-
Hunter.
Do I hear a second?
Second.
All in favor, say aye.
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 All opposed, nay. Ayes do have it. The quorum requirement is waived. Good afternoon, everybody, or good morning to some of you in different time zones. Thanks for everyone to join in the meeting today, and everybody's busy. I really really appreciate your participation today. The purpose of today's meeting is for the committee to continue discussion on the in-coil biomarker testing insurance coverage model act, sponsored by New York Assemblywoman Pam Hunter, in-coil treasurer, and then also co-sponsored by Minnesota Senator Paul Uke, in-coil secretary. As a reminder, the committee will be voting on the model during the in-coil summer meeting in July. So this meeting is primarily an opportunity to discuss the specific comments and suggestions and revisions to the model that has been submitted thus far. The committee meeting in July will be revised only for a brief comments and then a vote. I really do urge everyone to speak up today and not wait until July, as the committee will have other business to work on that meeting. Since the time of announcement of this interim meeting, we have received 2 letters with specific comments on the model, as well as a letter of general support of the model. The letters with specific comments were submitted by Blue Cross Blue Shield Association and American Health Insurance Plans. The general letter of support were submitted by a large constellation of organizations. And all that information, as well, the prior committee minutes and prior minute letters, are on the INCOR webpage for this meeting. Let's get started with the discussion. with the sponsor of the Model Act, Assemblywoman Hunter. Will you please go ahead, Assemblywoman Hunter?
Yes, thank you very much, Mr. Chairman, and I appreciate you calling this meeting to order to further this discussion about this very important model. And I'm looking forward to hearing comments today from everyone, and also for voting on the model in July. This model truly is a great opportunity for NCOIL to be involved in what can be truly described as a groundswell of support for this very important issue. Legislation similar to this model has been enacted in 9 states, and it has been introduced in 12 other states, including my home state of New York. And just as a point of reference, just this past week, today is Friday, so Wednesday, we had our insurance committee meeting in New York. This model passed through the insurance committee, bipartisan support unanimously through the insurance committee in the state of New York. So this is not a blue state, red state issue. This is a consumer people issue.
Sorry, give me 2 seconds.
When something reaches this many states, it can't be dismissed as something only a few handful of states are entertaining. This needs to be recognized and described truly as an emerging trend in healthcare public policy. One thing I'd like to mention again, because we've had this conversation before during the times we've held the committee meetings, is this model is intended to deal only with biomarker testing post diagnosis. You have been diagnosed with cancer, then the option for biomarker testing is then introduced, and it's used to determine the most effective treatment options. So we're not just talking about just having testing and having that testing covered by insurance at any time. So I want to make that very clear. We trust our doctors, and they're not having willy-nilly, tests, but this is after someone has been diagnosed with cancer, then if biomarker testing should be required, can be required based on the type of cancer that has been diagnosed, this should be an option. Accordingly, enacting this type of legislation in states should theoretically save money. Remember, I had said this before, we had conversations about doing breast cancer screening. We had the same conversation, and this is pre-screenings. I had conversations about colonoscopy, prostate screenings, and oh my gosh, it's going to cost so much money. We can't do it. And then look at it's everyone is doing it across the country, and it has been saving lives and saving money as preventative measures. This is again post-diagnosis, but wanting to make sure we're saving lives using the best treatment options that we have available based on the specific targeted type of cancer that you have. Okay. Let's see here. I'm open to making changes to the model. Again, we've been having this conversation for a year, and the only opposition we've received is from health plans, which we're not surprised about that. We have received limited comments from our colleagues, my colleagues here at NCOIL for the past year that we've had this conversation, but wanted to do this in advance of the 30-day material. So we give you yet another opportunity over this past year. If you have any additional information or questions or concerns that you have, that you could bring those forward so that we can finally close the chapter on this biomarker legislation, and that you all can bring it back to your states and do what you'd like to do. And I don't know if Representative Oliverson is on with us today, but I believe it just passed Texas this past week or last week. Thank you very much, Mr. Chairman.
Thank you, Assemblywoman Hunter. We'll now move in the discussion of the model. In terms of format, we'll hear first from interesting people, persons, and then from legislatures. If you already submitted a letter, please do not repeat what's in the letter. Please either supplement the letter or address something in the letter submitted by someone else. Any interested person would like to make any comments, please feel free to jump in, say your name, who you represent, and when you have raise your hand function available in Zoom, the staff will be monitoring. So who would like me first to speak and talk about this? So Will, do you see the hands or anything, recognize somebody, or somebody just jump in?
Yes, Mr. Chairman, we see first is Hillary Geckner from the American Cancer Society.
Okay, Hillary, go right ahead. You're muted. You're still muted.
I'm so sorry, hit it
There
twice.
you go.
Still early on the West Coast.
Yeah.
Hillary G. Geckner with ACS CAN, Director of State and Local Campaigns. Really want to thank Assemblywoman Hunter for her leadership on this important issue. Urge your support for the model. I'm just going to make a very few brief comments in response to some of the opposition letters. As a reminder, biomarker testing is all about connecting patients with the most effective treatment for their conditions. As Assemblywoman Hunter noted, there's broad bipartisan support across the country. Breaking news this morning, in addition to the 9 states she referenced, plus Texas sent their bill to Governor Abbott on Wednesday. Oklahoma's just passed in the last hour and is on, that bill is on the way to Governor Stitt. So this is now in law in Arkansas, Arizona, Georgia, Illinois, Kentucky, Louisiana, Maryland, New Mexico, and Rhode Island as well. So really broad bipartisan support, exciting issue that states are getting legislation on the books so that more patients can benefit. There are very real gaps in coverage currently in both public and private insurance plans. Although most plans are covering some testing for some patients, they are covering some biomarker testing. Many patients who can benefit are missing out on the testing needed to make sure they have the right treatment plan. And so what this legislation does is level the playing field so that more plans are playing by the same rules because they're not all routinely covering necessary and appropriate, really standard of care tests. So one example is a paper I referenced in my letter that analyzed plans in every single state and compared those written policies for coverage of biomarker testing, only looking for testing in advanced non-small cell lung cancer, breast cancer, melanoma, and prostate. So these are really proven tests with many targeted treatments available. These aren't, particularly new, unproven or unjustified tests. And 71% of the policies reviewed are more restrictive than those really gold standard guidelines that every oncologist consults for determining when to order biomarker testing. And as Assemblywoman Hunter was noting, this legislation has very clear guardrails. This isn't any test under the sun that calls itself a biomarker test. It has to be covered. There are clear circumstances under which testing should be covered and also sources of evidence that must be met in order for a test to qualify. So the circumstances are diagnosis, treatment, ongoing monitoring of a disease or condition. And also those sources of evidence must be met. Those offer rigorous scientific and medical evidence to ensure tests are covered only when they're effective and providing useful information to inform the treatment of patients and really shape their treatment decisions. And timely access to guideline indicated biomarker testing can help achieve the triple aim of healthcare that everyone's always after, better health outcomes, improved quality of life, and reduced healthcare costs. By avoiding unnecessary or ineffective treatments. For example, some breast cancer patients might not get any benefit from years of hormone therapy that would also, have a lot of side effects and impact on quality of life. Some prostate cancer patients might actually choose to forgo surgery that can often cause really devastating impacts on quality of life for a really non-aggressive, slow-growing cancer that won't actually cause them to die any sooner. So having that information is really valuable to patients and their doctors to determine what the best, most personalized treatment plan is for a particular patient. So this language has been thoroughly vetted, received bipartisan support in 11 states and counting as of this morning, and endorsed by more than 50 patient and provider groups. A couple dozen of those signed on to the letter that you have in your packet for today. So we just urge your support for this data-driven, evidence-based policy, and I'm happy to answer any questions at the appropriate time. Thank you.
Okay, we'll save questions till last anybody has any. So I see other hands. So Will, who's next on the line?
Yeah, Mr. Chairman, it looks like in order of the hands raised, we have Patrick Pluce is next, then Randy Chapman, and then Miranda Motter.
Okay. So Patrick?
Great, thank you. We also would like to thank Assemblywoman Hunter for bringing this before NCOIL and thank NCOIL for actually taking up this piece of legislation. My name is Patrick Plews. I'm Vice President for State Government Affairs at the Biotechnology Innovation Organization, otherwise known as BIO. Many of our member companies research, develop, and manufacture biopharmaceuticals that are more efficiently and more effectively used in combination with biomarker testing. BIO fully supports the biomarker testing legislation under consideration, and we applaud the efforts by the American Cancer Society to pass the state legislation requiring health plans and Medicaid programs to cover biomarker testing. Continued advances in science and genomics are driving an increased understanding of human physiology and how diseases in the human body might work. As more biomarkers are identified, they have the power to greatly, greatly improve how we treat patients by providing researchers with new ways to measure disease activity, shortening the amount of time that is required to demonstrate if a therapy is providing benefit to the patient, allowing researchers to better understand how effective a treatment is against disease. Biomarker testing also allows for more efficient care delivery, which often means cost savings. By spending a little more upfront on testing, we can often find out if certain treatments will or will not work so that payers don't foot the bill for the treatment, and it's not a waste of time for the physician or the patient. Biomarker testing also allows doctors to identify patients at low risk of disease progression who don't need additional treatment or who will not benefit from expensive therapies, and allowing them to avoid this care altogether. This model legislation, as Hillary mentioned, levels the playing field so that various plans follow the same rules. And I'd also like to add that BIO also represents a number of manufacturers who are in the rare disease space that are outside of cancer. And there are applications for biomarker testing in the rare disease space. On average, it takes between 5 and 7 years to accurately diagnose, but also treat a patient. And in the rare disease space, which are often degenerative diseases, the longer you wait to find a treatment, the more irreversible damage you give to a rare disease patient. So with that, I thank the committee for taking this piece of legislation on.
Okay, thank you. The next, I think, is Randy.
Good afternoon. Thank you. I'm sorry to second to come off of mute. So I really appreciate the opportunity to speak before you all here today, and certainly understand the importance of this issue, both to NCOIL as well as to our members, those people, 115 million people that BCVS companies serve. And so, certainly we always want to ensure that our members are able to access the care that they need in the most affordable way that they can. And so in listening to the testimony over the past couple of meetings, and certainly to the words of the sponsor of this model, I wanted to respectfully suggest that in the language in the model that refers to coverage for biomarker testing for the purposes of diagnosis, treatment, appropriate management, and or ongoing monitoring of a covered person's disease or condition, I would suggest perhaps removing the diagnosis, and so it maybe would read the biomarker testing for the purposes of treatment, appropriate management, or ongoing monitoring, and so forth, and even to put in post-cancer diagnosis, as it seems to me that that would be clearer in terms of getting to the goal that Assemblywoman Hunter stated for this model in terms of the coverage parameters. So I wanted to, I know we've put in our letter, and I don't want to repeat anything there, but I just wanted to add that for the committee's consideration, and happy to take questions at the appropriate time. Thank you.
Okay. Next up, I think, is George Lang.
Mr. Chairman, I think we're gonna do interested parties first and then move to legislators. So I think.
Yeah, do we have
next-
any interested parties? Yeah, anybody besides the legislatures? Then we will go to legislators.
Next was Miranda Motter from AHIP had requested to speak.
Okay, Miranda?
So thank you, Delegate Westfall and Representative Roberts and Assemblywoman Hunter. for the opportunity to engage with this committee and members of NCOIL, really, as Assemblywoman Hunter indicated, over the past year and a half on this draft biomarker testing model. So again, we specifically appreciated the opportunity, I know, to present on this topic in the fall of 22, and we recently submitted a letter on May 11th in advance of this call, and I know you all have that sitting in front of you. And in our letter, let me just, quickly point to two things. We really thought it was important to, highlight the testimony that the committee received from purchasers of healthcare. So during the committee and over the course of the year and a half, the committee did hear from employers that are purchasing biomarker testing today. The committee also heard from California in their employee benefit plan and in their Medicaid plan relative to the biomarker testing that they are purchasing today. So we really wanted to just highlight those 2 points as it relates to those purchasers of healthcare, not just health plans, but those who are actually purchasing biomarker testing today. And again, the 2 points I would make is, we really do believe, and you have heard testimony that health insurance providers already do offer, and purchasers of health insurance coverage, including employers and states, are already purchasing biomarker testing coverage when that testing is clinically valid and it provides clinical utility. The second thing I would just emphasize is you have heard, I know, over the past 2 years that employers and public purchasers of healthcare, including your own state Medicaid programs, that they are concerned about the rising cost of healthcare and health insurance. And so, we really do believe that with some of the, I think, more expansive definitions included in the model, that they could lead to more expensive and unnecessary cost and additional cost for those employers and employees. And you did hear testimony to that effect from Eric, particularly just a few months ago. In addition, I know BCBSA in their letter reflected a fiscal note relative to a pending biomarker testing mandate there in Ohio. That does talk about the additional testing cost that the state legislature will have to allocate funds for and taxpayers will have to pay for. And so again, as a result of that testimony that that you all heard, we really just believe that action at this time by NCOIL isn't needed. You did hear from Assemblywoman Hunter and others that where there may be a need, states are moving forward. And so we would just respectfully request a no vote on the draft during the upcoming meeting in July. Thank you.
Do we have anybody else want to speak about this before we go to legislatures?
So I see that, Mr. Chairman, Hillary has her hand raised, but before Hillary, are there any interested parties that haven't spoken yet that would like to speak? Okay, Mr. Chairman, so it would be Hillary would be up next.
Okay, Hillary.
Thank you. Just wanted to offer a few additional comments about the purposes of diagnosis. So biomarker testing is largely referred to as diagnostic testing. And this is separate and distinct from a screening test for a general population. So, you might have genetic testing if someone in your family is diagnosed with cancer or something, or a mammogram is a screening test that everyone goes for generally. But a diagnostic test is really helping to subtype a diagnosis and narrow down. So, Patrick was talking about rare disease diagnosis. This isn't something that everyone walking down the street is going to go get a diagnostic test to see if they might have something. This is, someone who is under a doctor's care for a treatment or condition, and accurately diagnosing that in order to determine the best course of treatment. So I would say diagnosis is an extremely important situation for when this testing is appropriate. And then also, as Patrick touched on, there are applications outside of cancer. Naturally, I work for the American Cancer Society, so that is our focus, but there is lots of exciting work happening in other disease areas. And as you'll see, the coalition that is supporting this legislation represents many different disease groups. So rare disease, autoimmune disease, like arthritis and rheumatoid arthritis, there are current applications. Just today, the FDA approved a biomarker test for preeclampsia to help determine among women who have preeclampsia, about a third respond to a particular treatment. And so knowing ahead of time before you give a pregnant woman a presumably very expensive treatment that could cure her preeclampsia, but you want to know, is she one of those 1 in 3 women who will have an effective response to that? Or is it not going to do any good to her or her baby to give that particular treatment? So I would encourage you all to keep this disease agnostic, as have the 11 states that have passed this legislation to date. Thank you.
Anybody else before we go to legislatures? Going once, twice. Okay, we will now go into legislature, and I see George does have his hand up. So go right ahead.
Thank you, Mr. Chairman. I appreciate Assemblywoman Hunter's intent in bringing this legislation forward. I was diagnosed with stage 4 colon cancer. It ended up being an advanced form of stage 3. So I'm a survivor, but I appreciate the intent of this, but I am strongly opposed to this bill and what this bill does. This will essentially, to me, comes down to government interfering with the private sector, with private markets. We should not be telling health plans what they should and should not do. Those health plans, I think it's a good idea to offer this. I think this will ultimately drive down costs, but those health plans that want to offer it, they can price it into their plan, and they can compete against those plans that do not want to offer this. And another big concern I have, this only affects the little guys. Those companies that are the heart and soul of every one of our communities. If you are a large self-funded plan, you come under ERISA, and what we pass at the state will have no impact on them. So this will only potentially increase costs to the small guys, and they're struggling right now to survive with supply chain issues, with inflation issues, with workforce development issues. And for most businesses, not all, but for most, employee benefits are their number 2 cost. I don't want to put this burden on these small businesses. And I've heard some testimony today that this will help level the playing field against various plans by making sure everybody's playing by the same rule. That's not government's job. That's the free market's job. They will have winners and losers as a result of what they put forward. Health plans will enjoy the benefits of good decisions or suffer the consequences of bad decisions. And if there is an advantage for this in the market, which I believe there is, employers can use this to their advantage as well when it comes to recruiting employees. I believe over time, the private sector is going to handle this, and it doesn't require government intervention. And if it really will lower costs, as I think long-term that it will, then the private sector is going to naturally do this on their own because they want to lower costs as well. So, Mr. Chairman, thank you. Assemblywoman Hunter, thank you for bringing this forward. And I stand in opposition.
Okay. Will, who's up next?
Up next, we have Colorado Representative Michelson Junaid, and then Washington Representative Mylin Tai.
Okay.
Good morning. I'm Daphne Michelson Junaid, currently coming to you from New York, but state representative from Colorado. And I just carried this bill through, we made it through committee, but we didn't make the final steps, but it was fully bipartisan. We made it almost unanimously out of committee, and believe very strongly in the concepts behind this bill regarding a focus on saving people money on healthcare. I am a 2-time cancer survivor, and I will tell you that being able to find the right treatment as opposed to trying this and trying that and seeing what's going to stick is very much an efficiency and an efficiency model that I would like to see adopted in our insurance plans. I understand that it's not going to be those ERISA funded plans that are covering this, but we can start somewhere. And the quality of life for the Coloradans who will benefit from this biomarker bill when this does pass and get to the governor is very much worth the effort of going forward with this bill. So thank you, Assemblywoman Hunter, and thank you, Chair Westfall.
Thank you. Okay, next, go ahead.
Thank you, Mr. Chair. For the record, I'm Representative Mi Lin Tai from Washington State. I am a trained pharmacist, and so I am going to speak in support of this proposed legislation by Assemblywoman Hunter. Washington State, similar to Colorado, have been working on this piece of legislation, and we have heard testimonials pretty much similar to what this incredible committee have heard. At the same time, as a healthcare providers, I'm sharing with you from that perspective. As a healthcare providers, when we see incredible advance when it's come to medicine, when it's come to many of the technology that could not only save lives, but it interfere with the decision making between the physicians, the providers, and patient. Sooner it save not only the government money, but patients' money. And so we look at multiple different directions for why a piece of policy is being introduced. It's about not only just efficiency, but it's really about safety and efficacy. And when we look at safety and efficacy, just imagine medication that's currently available for treatment of any kind of cancers or any kind of rare disease. As a pharmacist, I would tell you, not every single medication is completely safe. And so if we only sort of experimenting medication for treatments of people who are trying to take care of their loved one, biomarker testing is a game changer. Is making sure that the medications that is available for that particular condition is a match. So we're not playing games with people's lives. We are actually treating people using data and information that is now available for us. In the past, that was not available for providers nor for patients. And so why are we not using what's available to provide the best healthcare possible outcome for our patients? And for that, I not only endorsing this proposal, but really calling out for all insurance, big, small, government, private, to really looking at this potential life-changing testing so that we all share the same underlying mission, providing the best outcome and the best service available for our patients and our clients. And I thank you for the time to share my thought.
Okay. I see Representative Matt Lehman raise his hand.
All right. Thank you, Mr. Chairman. Thank you, Assemblywoman Hunter, for bringing this. I kind of echo a little bit of what Senator Lang said. I'm very concerned on a front half of this. If this is, as I think as Assemblywoman Hunter noted, we want to be very clear this is post-diagnosis. And the industries people I've talked to have said, you know, if I, both from the physician standpoint and from the pharmaceutical standpoint, if I can take someone who has been diagnosed and put them on the right path for treatment, long-term, it may actually be cheaper cost than upfront. And so I'll go back, I've been in the insurance business for 30 plus years, and I'll go back when I don't do health insurance anymore, but one time when I did, years and years ago, carriers were not big on paying for preventative care. They didn't want to pay for preventative care. And now they do because they see the benefit of getting people healthy. The utilization goes down. if we can get people onto the right process and get utilization down post-diagnosis. I have the same concerns pre-diagnosis. You're into the whole thing of maybe, and I don't know the health plan should be in that position to do that. The other thing I'll agree with Senator Lang is we've got to, the bigger picture here is, and I know NCOL has been pushing this, is we've got to start cracking that nut of ERISA. These are state-run, a lot of these are state-run plans, and we can't touch these plans because of ERISA. But what's driven people to ERISA is the cost of care. I just talked to a large group the other day, large in the sense of maybe 100 people, who said, we've been a fully funded plan for 30 years. We've now gone self-funded. They immediately switched from being regulated and taken care of by implementations we do on the state level to now the federal level. And ERISA is doing nothing. So I really think there's two things at play here. One is we've got to make sure we narrow this to post-diagnosis, and then moving forward is continuous discussion of health plans especially need to be brought back to the states for control, even if they're self-funded outside of ERISA. So those are basically my thoughts. I would like to see this keep moving forward, but I do think if it's not clear, we need to make it very clear that it is post-diagnosis.
Okay. I see Mr. Lang has to leave. George, you want to say a few more words?
Thank you, Mr. Chairman. No, I don't really have anything to add. You know, I do believe this will lower costs, and I believe that the private sector has a stronger interest in lowering costs than the public sector does, because especially in this scenario, because they are the ones ultimately responsible for paying for it. And I appreciate everybody's comments today, but my position is still the same. I think it's a noble effort, and as a survivor, I get it. But, you know, just to further illustrate my position on this, I am totally deaf. I rely on 2 cochlear bone-attached hearing aids that you can't see there in the back of my head in order to hear, as well as my ability to read lips. And when the Hearing Aid Association came to me to force private insurers to supply hearing aids for kids, what a great idea. I would like to see every private insurance company do that. And since I'm the only deaf legislator in Ohio, they thought I'd be their go-to guy. And I had to tell them no. Not only will I not move it forward, but if it moves forward, I will strongly oppose it, because I think in general, government should not be interfering with private markets. Appreciate everybody's opportunity to listen to me. And I do apologize. I do have a hard deadline at 12:50 Eastern time that I will have to be cutting out for. Thanks,
Okay.
everybody.
We have any more legislature before we go to Assemblywoman Hunter? Anybody else? If not-
Mr. Chairman, I'll just note for attendance purposes, since we started, I see New York Assemblyman David Weprin joined, and also West Virginia Delegate Walter Hall. Are there any other legislators that have signed on since the beginning?
Yeah, no, I appreciate joining in. This is David Weprin from New York. I'm the new chair of the Insurance Committee, and we actually just passed Assemblywoman Hunter's bill out of my committee this a couple of days ago. So we're looking to close down our session, and this is something that we'd like to see happen in New York. And I know we're going to hear from Assemblymember Hunter shortly.
Okay, Assemblywoman Hunter, would you like to have some closing remarks?
Yes, thanks. To close, I just would like to mention again, is that this model is really focused, intended to deal only with biomarker testing post-diagnosis. I just want to reiterate that, post-diagnosis. And I feel it's important to say I can absolutely understand the free market and allowing, you know, private businesses to grow and thrive. But when they fail to meet the needs of our constituency, then it is incumbent upon government to step in to make sure that all of its people are taken care of. And that is what we're trying to do with this bill right now, this biomarker bill. is that there's huge healthcare disparities. We have talked about this for the last 6 years that I've been attending NCOIL, whether it be in states that don't, opt in fully to Medicaid, to where people live in their zip codes where there's huge health disparity. This is a level playing field for people to be able to get the treatment based on the cancer that they have been diagnosed with. My mother has died from cancer. My husband has had cancer. Both my sisters have had cancer. And maybe this isn't, oh, you don't have a unique form of breast cancer, so maybe radiation and chemotherapy is for you. But you're talking about filling people's bodies with deadly chemicals when maybe they are not necessary, when simply using a biomarker test after you've been diagnosed with cancer could save your life and give you meaningful quality of life going forward. So to me, this is a no-brainer. To me, it's incumbent upon us to make sure we're taking care of all of our constituency, not just business, not making sure that we push back. Sometimes we agree with the plans and sometimes we don't. And sometimes it's incumbent upon us to push that forward if we feel that the needs of our constituents definitely are not being met. So I look forward to having this conversation in July in Minneapolis and look forward to this model being passed, and you can take it back to your state and work it through however you may need to work it in your state. Thank you very much, Chairman Westfall.
Thank you, Assemblywoman Hunter, and thank everyone else for joining us today. Be sure to submit any thoughts, comments on the model to Assemblywoman Hunter, Senator Uke, myself, or NCOIL staff. We got a little bit other business here real quick. Before we adjourn, registration is still open for the NCOIL summer meetings in Minneapolis is open. If you haven't registered and want to do so, please do so quickly. Reminder, the first day of the meeting, we'll be holding another golf outing to benefit the Insurance Legislature Foundation Scholarship Fund. If you haven't registered and you want to, please do so before it sells out. I played in New Orleans. It was a lot of fun. I'm not going to make it to this one, but I will be in NCOIL meeting. You can find all the meeting and golf restoration information on the NCOIL website or reach out to NCOIL staff. Is there any more business before the committee to raise? Anything else? If not, we need a motion to adjourn.
So moved.
We need a second.
Second.
All in favor, say aye.
Aye.
Opposed, nays. We are adjourned. We'll hopefully see everybody in July in Minneapolis.